most of us work with psychiatric disorders of various kinds, and many of them may be accompanied by social skills deficits for a variety of reasons. Sometimes when the disorder begins quite early in the developmental life cycle, opportunities for social interactions and learning social skills may be curtailed to some extent. The symptoms themselves may be directly or indirectly involved. For example, social withdrawal in depression or persecuted delusions in schizophrenia that sort of impede social functioning. And sometimes impairment in social skills or social cognition may be a hallmark enduring deficit of the disorder itself during its course. We now, all of us here work in a rehabilitation setting, and we're looking at a recovery-oriented approach. That, in essence, means that we're trying to function on the, look at the best potential of the person, trying to improve the person's functioning. And I think social inclusion is also one of the things that we aim towards. So given all of these things, and the fact that in a rehabilitation setting, we are likely to see more serious and persistent sort of mental illnesses, we felt there's a need to really be quite aware of structured social skills assessment and intervention modalities for select clients. So today's Road to Recovery program focuses on that. First, Ms. Vidhi Tyagi will give us a little bit of introduction on the construct of social skills and focus on the way that we try to assess social skills here in our setting. And then we will move on to social skills training from the Manipal group. After the first presentation, we'll stop for any questions or clarifications or any contributions from your side. We'd love to know what you are doing in your settings as well. And so we'll take your questions as they come along, collate them, and stop at the end of Vidhi's presentation. So over to Vidhi.
Good afternoon, everybody. I welcome you all. And just continuing from where ma'am has ended, we'll be focusing over here on assessment part. So I think we all may agree that for any intervention to be successful, to know our clientele better, we need to have a comprehensive and structured assessment in place, which help us in planning a structured and a tailor-made intervention. So before going as to what we do over here in assessment part, we'll first discuss about the various components of social skills. So as you can see in this slide, there are various components of social skills, which are social and problem solving skills. So we can say that there are social perception skills, problem solving skills, and behavioral skills. The social perception skills involves accurately perceiving the relevant situational parameters, such as relationship of the client to the other person, whether setting is public or a private setting, and the other person's effective response to the interaction which one is having. The other is the problem solving skills, which involves generating possible response alternatives for achieving the goal, for weighing the pros and cons for each possible solution, choosing the best solution. So problem solving skills involves the higher cognitive functions like abstract thinking, memory, and cognitive functioning. Behavioral skills, which involves the actual behaviors which are emitted in interpersonal situation that are necessary to achieve a particular goal. There are 4 different areas which we'll be seeing in the next slide: non-verbal components, the paralinguistic skills, the verbal content, and the interactive balance. So the non-verbal behaviors involves the eye contact, facial expression, posture, use of gestures, body orientation, interpersonal distance. Whereas paralinguistic skills, loudness, tone, pitch, effect, rate of speech, clarity of speech, and duration of utterance from an individual. The verbal content will include the verbal message, the choice of wording by an individual, the appropriateness of self-disclosure, and interactive balance involves the smoothness of turn taking as we are initiating a conversation, how the individuals are talking and how they are involving a turn taking, and there's a smooth transition of conversation which is happening. Use of social reinforcers and balance of time taking. So there are various assessment strategies which we follow while doing the assessment part. As you can see, there are self-report measures, there are report by significant others, naturalistic observations, and role play test. All of them, they have their own merits and demerits, and for a better and smooth assessment, we need to include some of the aspects of each and every assessment strategies which we are using it over here. For self-report measures, it's usually the social and problem solving skills based on either the questionnaire or the interviews which we give to the client. The report by significant others involves directly experience the consequence of poor skills in clients and may be able to pinpoint specific situation in which these skills are most prominent. It is very pertinent, it becomes quite pertinent when it comes to psychiatric illness, that a report by significant in others is relevant because they are the ones who are spending most of the time with the client. So report by any significant others, maybe a caregiver, maybe parents, siblings, friends, it is quite necessary. Then we move on to naturalistic observation. Naturalistic observation is it has more of a high generalizability to the social environment which clients face. So we are observing the client in a more natural setting. It can be easily performed in certain settings in which clinical staff have regular contact with clients. It provides information at a level of specificity necessary for targeting behaviorals and skill training. There is an example for that is a test of grocery shopping skills. The next we move forward to role play test. The role play test involves the engagement of clients in a simulated interaction, which may be recorded and later rated on different dimensions of social and problem solving skills. One example of that is the Marillion assessment of social competence. So what we do in rehab settings, how the assessment comes to us, how the referral questions comes to us, what are the typical referral questions which we come across in day-to-day practice, and who are the ones who bring it up. So usually the typical question involves that please evaluate for social skill deficits, patient has poor communication, interaction, there's nil participation in any social gathering, and usually it is as a felt need by the treating team, by the caregiver, sometimes by the clients themselves. So the question is that why do we need a structured social skills assessment in rehabilitation settings? Why there's a need for that? So need for a brief tool for structured assessment of social skills at the very first contact with the patients in the rehabilitation setup that can be built into the routine clinical process. So why there was a felt need that the moment the person is having the first contact with us, it becomes important to have a structured and a routine clinical and a short duration where we can screen the individuals at first contact, understand the pattern of deficits and the strengths of the individual as well, in-depth understanding of patient and the context. It can be followed by a more detailed evaluation using role plays, observations, and other methods. It also helps in planning individualized interventions and initiate individual or group social skills training. So I'll just give you a brief about what kind of patients, what type of clientele we've seen in psychiatric rehabilitation services. Basically, we have 2 inpatients and day boarders. Inpatients are usually referred by the treating adult psych units, and mostly we have 5 to 10 inpatient referral per day. At times, depending upon the numbers increase and decrease accordingly. Then the second is the day boarders, which are around 40 to 50 at a given point of time in a day. They are the ones who are all these inpatients and our day boarders are the ones who are availing the various services which we provide, psychiatric rehabilitation services. So the inpatients, they are typically referred for vocational rehabilitation, establishment of a daily activity schedule, social skills training, and cognitive rehabilitation. The inpatients are referred for varying durations from days to months based on the felt needs and practical issues like length of hospitalization. For day boarders, similarly to the inpatients, they are also referred for like cognitive social disability assessments, individualized and family interventions, home-based rehabilitations, caregiver groups, and licensed with community organizations to support and competitive employment. The center at Psychiatric Rehabilitation Services is staffed by nursing staff, consultants, and trainees from multidisciplinary backgrounds. We have an intake pro forma for both inpatient referrals as well as the day boarders. We have an intake pro forma service worker for inpatients and day boarders respectively. Also, it mentions about the requirement of various interventions required, of which social skills training is an essential component. It is seen that social skills training is the third most frequently mentioned reason for referral. 17% of all our inpatient referrals over a 5-month period, it was seen in a study in 2014. So coming on to the assessment part, the social skill assessment scale, it was developed by Psychiatric Rehabilitation Services team. Nimhans was based on the clinical experience in rehabilitation settings, the felt need for assessing social skills for adult inpatients referred to Psychiatric Rehabilitation Services, and it was also based on theoretical models of social skills components. So the social assessment scale is a 20 items across 3 domains we see: non-verbal behavior and communication, verbal communication, social behavior. The additional information is provided for items which are marked as asterisk. We will be discussing about these additional information when we were discussing about the case. It's a 2-point rating scale of inadequate and adequate. Ratings are done on the basis of observations, interview with the client and caregivers, and case file data and referral information. There are 10 open-ended questions as well. It can be used for mental health trainees and practitioners. So we were discussing about the performer, which we used over here. There are various domains in the performer. There are structured ratings of 20 items, which involves non-verbal behavior and communication, verbal communication, and social behavior. Whereas we have 10 items in open-ended questions, which involves specific questions in client and caregivers' need for enhancing skills, areas that require change. It involves a component of pre-morbid personality, psychopathology, variations across situations which caregivers feel, anxiety or medication side effects, and limited opportunity for interactions if the individual had. The non-skill factors also play a very important role. So sometimes we see it's not just the individual, non-skill factors are basically the involvement of both the individual as well as the environmental factors which are playing a role in deficits seen in social skills in an individual. So not all impairments in social adjustment are specifically result of deficits in these skills. The recognition of other factors which can also affect the social functioning is critical, since successful intervention may require attention to these factors as well. So what are these factors? These are medication side effects, mood of an individual, other psychiatric symptoms, environmental factors, and cultural norms as well. So we'll have a case minute, which and we will discuss in details about the various components which we have done on this patient. Index patient essay, 32 years, married male, studied BCom and BEd. He's hailing from Srinagar, working as a teacher, teaching class 3 and class 4. He teaches maths, Urdu and English. Is presented with 8 years duration of illness characterized by delusions of persecution, referential ideas, social withdrawal, poor communication, lack of initiation, difficulty in managing students at school, and non-participation in social functions. So going to the first domain, the non-verbal behavior and communication, it was seen that he was scored adequately on grooming and appearance, in establishing and maintaining an eye contact, in ability to using gestures and facial expressions, and ability to maintain interpersonal distance. As you can see, there's an asterisk sign on ability to maintain interpersonal distance. These specific questions calls for a more detailed evaluation, and interpersonal distance specifically refers to a patient's ability to maintain adequate distance while interacting or communicating with others. It also includes the ability to understand and respect the interpersonal boundaries while working or interacting. Inadequacy of this skill would be reflected in terms of intrusive behavior, being too close or too far apart while making conversations with others, etc. So as we can see, there was there was adequate adequate communication, nonverbal behavior was seen in this patient under this domain. Moving on to the verbal communication. Ability to greet other people appropriately, to initiate a conversation, to take turns in a conversation, and communicate a message meaningfully. All these things, in greeting other people appropriately, in initiating conversation, in taking turns in a conversation, and the paralinguistic speech of an individual, it was seen that it was inadequate, while on listening to a conversation and communicating his message meaningfully, the patient was adequate in these domains. As you can see, the taking turns in a conversation or communicating a message meaningfully, it basically involves ability to express what one intends to express. That the patient needs to have ability to express whatever his emotions and other aspects of his life. It includes the use of complete meaningful sentences to convey a message rather than using minimal words or gestures. So it involves both verbal as well as non-verbal component. Moving on to the social behavior, it involves understanding social situations, formal and informal situation, ability to change behavior according to situation, formal as well as informal. As you can see, he was inadequate score was, you can see over there. Knowledge and use of appropriate manners, ability to engage in activities with others, ability to use appropriate language to sustain a conversation and interaction, to express or share one's day-to-day experiences, to express and share emotions, to help others voluntarily, and to empathize with others, understanding their perspective. So specifically, I'll elaborate on the 20th item, which, as you can see, to empathize with others, understand their perspective. It refers to the ability to understand another person's perspectives, their emotions. For example, understanding that engaging in behavior such as teasing others, expressing anger, either verbally or physically, are unpleasant for the individual being subjected to the same and would disturb or hurt them. So it involves a component of empathizing with others. It also includes the ability to understand another person's feelings and needs and responding appropriately. For example, the caregiver is unwell. Instead of getting angry, the patient is responding appropriately. So in certain domains, you can see inadequate and adequate along. So moving on to the open-ended questions. There are a few of the questions and the response which we generated from the assessment. So as you can see, then the first question, does the client indicate any need for enhancement of social skills? If yes, what are the areas that the individual wants to work upon? So client says that he feels a need for enhancement of social skills, specifically in terms that he wants to mix up with other people, make social contacts, participate in social gatherings and functions. So whether this is something which the client only feels or the caregiver also responds in the same way. So the caregiver responds that he needs training specifically in the areas of communication, initiating conversation, participation. When we asked them to elaborate a little further, the caregiver responded that whenever they're going for any social gathering, usually they see that the client will resort himself to a corner and will not interact or initiate a conversation by himself. Usually whenever the other family members will come and greet them, only then there is conversation from the client side. So there's a component of pre-morbid personality. Patient's interaction at home with family members and siblings is adequate. He had few friends pre-morbidly, but there was no major problems in interaction. So the next question is, please comment on variations, if any, in information about client social skills across different situations, whether these skill deficit is seen specifically at home setting or social functions, or when a client is interacting with authority figure, or specifically with females or with his colleagues, or any specific gender when he's interacting with. So father reports that at home patient is more comfortable and opens up to the family members and discusses his day at home with his wife and parents. However, in school where he works, he's not very open and he's with his fellow teachers, and while sitting in the staff room also, he does not interact with other teachers. He has difficulty in interacting with with his school principal as well. So there's one more component in the which we spoke about previously, about non-skill factors. So these are can the observed social skill deficits be attributed to one or more of the following factors? Non-skill factors including the ongoing psychopathology of the client, the social anxiety, any medication side effects, limited opportunities for social interaction. So ongoing psychopathology can be, for this client, can be a part of patient's negative symptoms. Previously, whenever he used to go to market or outside, he used to have referential ideas, so he was not very comfortable. Social anxiety was not evident. Similarly, there was no medication side effects. When it comes to limited opportunities for social interaction, we need to, which will be a very important point when we plan an intervention for the patient, that he's from Jammu and Kashmir, and father says that there's a frequent unrest in the state, so they prefer to keep him at home. So as you can see, there's limited opportunity. Even the patient was not provided an opportunity to find kind of a social interaction which he would have had. So coming forward to assessment, the way forward for social skills assessment, the training for social skills assessment should incorporate an understanding of clients' cultural context, in-depth assessment for targeted domains of social skill deficits using role play minutes, further assessment of social skills deficits manifest in specific situations, example, workplace. So we need to assess that specific situations are generating certain deficits in an individual that needs to be assessed. Use of social skills assessment scale for changes seen post-intervention can also be done. As we have seen in the initial slides that we have spoken about the component of social perception, it's a more broader broader component of which comes in social cognition, which involves not just social perception, but theory of mind, attribution style, emotional processing. So from moving on from just the neurocognitive aspect, the social cognition, only social perception aspect, and the social and functional skills, we need to go a little forward and involve the other aspects, social cognition as well, which involves emotional processing, theory of mind components, and attribution styles. So some clients may require further assessment, which will help us in getting a more detailed evaluation of them and thus planning a more better intervention for them. So there is a need for a brief, feasible assessment methodologies, which can be done in less amount of time, and it's more structured, which will help us in planning a better intervention for our clients. So just coming towards the end, just adding that the assessment tools provide a lot of comprehensive picture of our client, which usually helps us in identifying their baseline deficits and planning a more structured, more feasible targets for them, and realistic targets, which helps us in achieving our short-term as well as long-term goals.
One of the things that I would like to bring up, and I would really like responses from other participants as well, is that it's all very well to assess social skills, but we're also looking at how do we see change post-training. Now, this tool really has, just adequate and inadequate as the two parameters. That's expecting the client to take a very big jump for, assessing post-training. So one of the things that we've considered is increasing the scale, maybe a Likert type scale 0 to 5 or 0 to 10, where we then use a similar assessment tool, assess pre-training and then assess post-training once again. So that's something that we've considered, and we'd like to hear from anyone else about what you think about this possibility.
We would like to know, how do we rate adequate and inadequate? Is it based on any anchor points, like on what basis you rate adequate and inadequate?
So initially when we sort of made this measure, I think we considered having a wider rating scale, because obviously adequate and inadequate is difficult to judge, and it's influenced by so many different factors. And I'm sure that's where the question is coming from. But what we found is that then it makes it quite tedious to use in routine practice. So we are looking at this more as a screening sort of measure. So we ask the trainees, typically we have a brief introduction to the scale right in the beginning of the trainees' postings, that you use it, you look at the person's background, you evaluate what the person's pre-morbid functioning would have been, look at any deficits related to that, and then give a broad judgment of whether you feel it's adequate and inadequate or inadequate. So there are no very specific anchor points, because we have clients who come from very many different backgrounds, and to fix clear behaviors that may indicate one or the other become a little difficult. There are a number of items where we've given additional descriptions. We haven't been able to share all of that with you during this session. So those descriptions help people to judge whether the behaviors are adequate or inadequate.
I have a question. May I?
Yes.
Yes, please.
Yes, ma'am.
Yeah. So, as I understand, you're basically trying to fix whether the person has a problem or does not have a problem, and you're not really looking at the gradation of the problem. So
Yes.
all interventions will depend upon how much, whether there is a problem or not. So if there is a problem, say even initiating a conversation, so your therapy will work towards trying to see how you can promote. Is that it?
Yes, yes. So we look at across how across how many domains the difficulties might lie, and so it's more like a screening for each of the observed deficits. Then we may do much more in-depth evaluation. Then we may set up role plays or observe those behaviors a little bit more carefully, and then be able to improve. So the gradation may well happen at a second level rather than at the first.
Okay. So then when you mean second level, post, initial screening, you do go into for more in-depth screening of social skills?
Yes.
Okay.
Yes.
So will you be talking about it in a while?
I think that we might find that the Manipal team will speak about some of these issues as well. we haven't taken this up in detail because it's quite individualized. For each patient, we may set up, for example, this gentleman has difficulties in his workplace. So we may set up role play scenarios, then observe and look more carefully at the pattern of deficits. So that doesn't use another structured scale. It is more in terms of observations and role plays in the specific domains. And much of this seamlessly kind of moves on to the training that we might start providing. So evaluation, in-depth evaluation and training seems to start almost together in a sense. Once we've seen that the person needs intervention.
Okay. Okay. Yeah.
I'm just going to, before we move ahead, I'm just going to ask if any one of our team members would like to share their experience in using this skill. Maybe I can request Dr. Chetan. He's had a lot of experience in using this scale. So has it been easy? Has it been useful? Are there some challenges? Maybe you could share.
We have been using this scale from past, say, about 2.5 to 3 years here. What we found was, as a screening tool, it is pretty helpful to find out which of the areas we need to concentrate. As you have seen, it has been divided into 3 broad domains, which will help us in focusing as to which domain the patient would need a lot of skills improvement. And once we find that out, then this scale is used by all trainees. I mean to say psychiatry, psychology, PSW, nursing, whoever the trainees, they can use this. Then when we find if there is any deficits in that, then we can refer them to clinical psychologists so that they can do in-depth analysis and then start training in social skills. But if anybody who is interested wants to understand, even if they do not have any particular training in assessing social skills deficits, the first day when they come and we give this, even then we were able to differentiate the adequacy and inadequacy using this scale. The other important factor was a lot of cultural factors were also involved. This scale to say that even if there are cultural differences, using this scale, we will be able to find out if there are any deficits. What we had also done was we had done a study. It will be soon published probably. We had correlated this with IDEAS, Indian Disability Evaluation and Assessment Scale. What we found out was, again, it was pretty interesting that this scale correlated very well with communication and understanding and interpersonal activities. So it also shows that IDEAS is a very good scale which is used by almost all of us to rate disability. And people who were more disabled in communication and understanding and interpersonal activities also scored less in social skills, also had more social skills deficits. So it also shows that this can be pretty well used across the country, because IDEAS was used across the country, and it has good correlation also.
Okay. So we'll move next to the presentation from Manipal. Dr. Rajesh Bhandary will be presenting a brief look at the context in which rehabilitation is done in Manipal, and also taking up a case where intensive social skills training has been done in different modalities and over a fairly long period of time. Okay. We can share details of the social skills assessment scale via email. If anyone wants, the entire scale can be sent to you along with all of the details. So I request Dr. Bhandary to please begin.
Yeah, good afternoon, everyone.
Are we audible?
Are we audible?
Yes.
Yes.
Yeah. First of all, I'd like to introduce, and though this mentions that it's only my presentation, I'll be sharing the speech, the talking part with Ms. Nitha, who has done the part of the therapy as well. And so I'll start beginning with the initial introduction about the functioning of our center, Hombelaku, and then move on to the individual case and giving a brief background about what the person was suffering and how his condition was when he was admitted at our center, and then what progressed from then onwards. Okay, telling briefly about our center, it's named as Hombelaku, means a golden ray of light, or giving them a hope for a future. This was a project initiated by our HOD, Dr. Praveen Sharma, and it is run by the Department of Psychiatry, functioning under the administration of Kasturba Medical College, Manipal, and supported by the Manipal University. It started functioning from 7th January 2010, so about 6 years now, and it's located within the campus in the residential area of the college quarters. And it shares its campus with another center known as ASRE, which is a residential and daycare center for the intellectually challenged. So this is a picture of Hombelaku, our center. It's a medium to long-term residential rehabilitation center. The whole infrastructure has been built from donations received from philanthropists. Then we had some 4 to 5 music concerts to raise funds for this center, and matching grants by the Manipal University. So it's almost like half the grants for the donations have come from the university. So in between, after we had an initial 32-bedded strength, then we had to, because of the increasing demand, we had to build an additional floor, and we reached 50 beds in December 2012. So this is our team, headed by Dr. P.S.V.N. Sharma, then myself, and Dr. Sonia Shenai. She's an alumnus from Nimhans. She's joined as senior resident here. She also helps us in this venture. Mr. Praveen, who is sitting on my this left side. Ms. Nitha Thomas, who is in the clinical psychology. And we had additional inputs from MSc, Ms. Shalini and Ms. Pavitra, who are from occupational therapy. There's a nursing faculty who come on rotation and teach the nursing students to join in the staff. So 2 vocational trainers, 3 caregivers, 6 housekeeping staff, and 1 security guard. Besides this, we have many of the training students who are involved in the therapy part. About 2 PGs are posted, psychiatry PGs, then 1 or 2 MPhil psychiatry social work students, 2 3 MPhil clinical psychology students, and about 4 to 5 occupational therapy students who involved in this. So just running through some of the objectives: to provide the highest quality clinical care, provide a nurturing environment, facilitate reintegration of the person back into the society, minimize the disability, and to provide a respite care for some of them. The beds are at a reasonable rate of general beds 5,500 per month, plus medicines and personal requirements. If they have, they get an additional bill. All professional inputs are provided without additional charges, and there is psychiatric consultation, psychology, social intervention, family interventions, OT, and yoga. And we also have a help of the university giving Medicare for these clients at rupees 2,000 per year, which provides them free investigations, free consultations to other departments. And if they have an acute emergencies or even a physical complication, 80 to 90% of the inpatient care is covered by this. The uniqueness of our center lies in the support provided by the university and the community at large, who have provided vocational training opportunities in their offices and in the various establishments like hotel and canteens, etc. So coming to the case, case as such, we had chosen this individual because we have been able to see him at a stage wherein there was very little prospects for how he will be coming out from here. And everybody was involved, a group was involved, and individual sessions, group sessions, and even the last step of screening or streamlining to the occupational requirement. So even that could occur in this individual. And since it's a success, it generally makes more sense in putting it across. Okay. So Mr. X is a male, 45-year-old. He's separated from his wife, Hindu, where he's been educated up to Bachelor's of Engineering, unemployed since the back, and he's from a higher socioeconomic status. He migrated to Australia after marriage for sake of his job, and 4 years after, when he came back to India, his wife was pregnant, and so for the sake of delivery, they had to come over. His family members noticed that his behavior had changed. At that time, they weren't really so abnormal. It was so abnormal that they felt the need to take him at urgency. But he complained of strange smells in the house, neighbors spying on them, lived with curtains drawn all the time while he was at Australia, and that smoke is coming out of his house. He had difficulty in breathing. His energy is drained out from his house, from him in the house, and even suspected the landlord below him of running a meth lab and informed police about it. For the family members, it was they believed initially because there was actually a chemical laboratory which was very near to their house, so they thought there may be some actual happening. In 2011, he started talking in odd fashion, would say that a black car was following him, would report of electric shocks being given, and unable to remember. And these are all made a plan so that he loses his memory. He believed that people were out to kill him, and if he is found dead, he used to give, these are the individuals whom you have to inquire, if at all I am found dead. In late 2011, on family's insistence, patient moved to his sister's house in Mumbai, where he started suspecting his wife's brother and family to be involved in this whole meth ring of the pseudo community who are doing this meth lab and chemicals, sending chemicals to them. He still reported that Australian people are following him even in Mumbai. However, his self-care and appetite was adequate, and during this time they felt the need to take him to a psychiatrist who diagnosed with a mental illness. We don't have any details, and recommended medication, but patient refused. The reason why I'm pointing out is that he has been off medication or have not received any treatment for almost till 2015. For the next 1 year, he remained unemployed in Mumbai, would be preoccupied with these suspicions, would also suspect workers at sister's house and everybody to be involved in that Australian drug mafia. During 2012, he and his wife moved back to Australia. He would wander about streets, was suspicious about the brother-in-law and the wife's family, some of whom were staying in Australia. It was also reported that wife believed that, and almost was a shared delusion at that time. And he would speak in low tones, have curtains drawn out in the house all the time. It was then that the family decided to see if whether separation will help them. So in November 2013, he came back to India. Wife is continuing to stay at Australia, and he continued to be symptomatic. He would not give his CV to get additional job or employment opportunities. And Jan 2014, he made an attempt to join as a clerical clerk in one of the establishments in Ahmedabad. However, he could not sustain there, and he had to come back after a few months. And once his aunt moved out, he went back to Australia. He was not in regular contact with family, and he had gone without informing anybody. And so, somewhere in mid 2014 till Jan 2015, there was no contact. So his sister receives a call from Australian psychiatrist informing that his brother was wandering, and he was refusing to talk to the doctors and complaining that the police were giving him shocks through their instruments. So after this, the psychiatrist suggested to take him back to India, as they had already and they had made arrangements for his travel. Once he came to India, he stayed with his sister in Mumbai, and within a few days he absconded from there and was found wandering in Karnataka and was brought to his parents' house through police and other. After that, he received acute treatment in a psychiatric hospital nearby and was admitted for 3 weeks, and then he was referred to a center for rehabilitation. So, pre-morbidly, he is generally a hardworking person. He is reserved, he is sensitive, prefers solitary activities, is a little introvert, and has some anxious traits. The support system was mainly formed by the father and elder brother when he reached to us, and secondly was the sister who ensured that he complies with the treating team. Tertiary, the rehab center has been providing support. Family history-wise, we have not got any significant, besides alcohol dependence in father and who is currently abstinent. So coming to how he was at the time of reaching the rehabilitation center, the mental status examination, was welcomed, moderately built, right-handed, eye to contact was made but not maintained for long. Facial expression kept looking up and down, response to question, very brief, 1 or 2 words. Attention was aroused and concentration was not sustained. Memory impairments in immediate memory, then depressed mood, blunted affect. When verified about any presence of positive symptoms, he just mentions about suspiciousness that people may do something, but denied any presence of those Australian drug people following him now. Negative symptoms was prominent during his the initial state. Motivation was found, asociality, affect was blunt, and was apathy. No depressive cognitions as such could be elicited or OC symptoms at that time. And he just mentioned about anxiety about his future, how he will be going ahead. Reasons were for low socio-occupational functioning and reluctance to take medicine. That was the primary reason why they had considered rehabilitation. So occupational functioning was low, not working since 3 years, and he had very lack of motivation to do any work. The role in the family had been an active member of the family, otherwise supported his wife and kid before his illness worsened, and currently he holds a sick role without involving in any decision making. Interpersonal skills and social involvement in the last few months, minimal social involvement, withdrawn, keeps to himself. This is the information we have got from the reports of the Australian, the discharge summary. Family expectation, already mentioned. Then skills possessed by the patient. In the past, he has had experience working in India and abroad, where he used to oversee construction work, prepare data sheets for the construction related activities, designing blueprints, as well as go for field supervision. Family vocation, their plans were only to get him a clerical job or a computer related job and be okay with that, despite his qualification. So in our assessment, so the diagnosis has been straightforward and paranoid schizophrenia, more or less a continuous course, and can say that it was almost untreated for about 7 to 8 years. And the flare-up at the Australian region had possibly made them get him into this treatment part. So among the assessments that we have done the disability as per ideas, it was 8, mainly scoring low on the, mainly scoring more on the communication and the interpersonal relations. Clinical global impression at the time of admission to our center was 4, moderately. And coming to the topic of discussion as such, that is the social skills. So here we use a checklist of social skills which has about 30 items. What Madam had pointed out, possibly some of them are split up into 2 or 3 components in this checklist. And so this is a set of which required improvement. So eye contact, initiating conversation, asking help, greeting, being an active participant, appropriate tone and volume, complimenting, interacting with peers. The prominent findings in the Wing SWOT behavior scale, which we use for regular monitoring the chain. Patient is socially isolated, does not initiate social contact, mild to moderate impairment in speed, volume, and amount of speech. So other areas were fairly well. So in our rehabilitation plan, we generally divide into various subheadings. Duration of stay. Initially, it was planned of extended stay from 6 months to 1 year. Target symptoms were to improve compliance and the socio-occupational functioning. So at these various headings, we have our interventions planned. So going to the psychological, that is the social skills. So I'll hand it over to Ms. Nitha, who was supervising most of these interventions. A whole group was involved with multiple postgraduates as well as staff in the skills training part. So over to Ms. Nitha for the next.
Hello everyone. I'm moving on to the social skill training that we did for this particular client, the FAST. So usually social skill training in our center has both individual and group skill components to it. So we started off because when he came to us, his eye contact he could make but could not maintain it. He would be socially isolated. So we thought initially some amount of individual social skill training would be beneficial, and that was taken up by Dr. Rajeshkrishna Bhandary. Around 5 to 6 sessions of individual skills were done. The areas we focused at this time were greeting, responding to greeting and eye contact, initiating a conversation, asking for information, and reporting problems. This last bit is quite important. Whether we don't want our residents to complain too much, we still would want them to tell us whether they have any problems in their stay, they're having issues with other fellow inmates and things like that. So I'll be taking 2 such sessions what we did as an example. Can I continue?
Go ahead, ma'am. Yes, go ahead.
Yeah. Yeah. One of the things that we did was the initial sessions was to respond to greeting and eye contact. So initially we would discuss the steps of the skill and discuss why this particular skill is important and why should you maintain eye contact. And we would shape and prompt for social interaction with individual therapist. So the therapist would ask the client, how are you? And therapist won't move out till the client answers. And then later the response is shaped to include items like eye contact, smile, verbal response, etc. So he has to look into your eye, smile at you and say, I'm fine or I'm not fine, whatever the need is. He was also given homework task involving staff at Rehab Center initially. So he has to go and greet another staff, or another staff will greet him and he has to respond to them. Or later with other fellow residents. So he has to go and talk to 2 other inmates of his room and talk to them. This homework task will be discussed in the next session, what went wrong, what went right, and what could have been done. Another one aspect of this individual training was to initiate conversation. So this time, the therapist models a role play with the patient himself, wherein a topic is taken and they are initiating a conversation. So the therapist is the one who initiates the conversation. Once this role play is done and discussed about what went right, what could have been improved, this role play is repeated by the resident. This time, our patient, the resident, becomes the person who's initiating conversation with another staff, and the therapist, the individual therapist, observes this particular interaction, this particular role play, and gives feedback to the client what went very well and what could have improved in the next time he does. Again, he is given homework task to initiate conversation involving staff at Rehab Center and later other fellow residents. So in this way, he received 5 to 6 individual sessions in social skill training, and once we felt that he's okay, he can interact with other residents, he was shifted to group skill training. Now, group social skill training is done in 2 ways. We have occupational group activity, which occurs in the morning session of our rehab. So every day around 9 to 12, we have these 9 to 11:30, we have this OT activity wherein each day the sessions focus on one thing, and one day the focus is on social skill. So there will be group games, group activities, they have to interact with each other, and the occupational therapist gives feedback about what is happening in the group. There is also a 1-day mandatory shopping day where the clients decide what to buy for themselves, and they all go out along with the OT therapist and go to a nearby shopping center and make purchases. This is supervised by the OT staff. This is again done so that the instrumental life skills are, we focus on that. Apart from this, we also have a social skill training group, which is primarily run by our psychiatry, psychology, and social work residents. These group sessions are usually weekly, 1 or 2. We follow Bellac's manual, and it is an open group. So at any point, there will be new patients coming in and old patients going out of this group. And the group focuses on these kind of skills: ability to listen to other people and let them know that you're listening, ability to make requests of others in a positive way, ability to express positive feelings to other people, to express negative feelings to other people, assertiveness, making requests, saying no, etc. And these skills are done in a group format with a group of similarly skilled clients together. So we divide our inpatients into different skill levels. And for each skill level group, we have different groups which are run. So the group session is usually after the OT session, and it's about 30 to 40 minutes. And the session starts by reviewing of the last session, introduction of any new clients, and discussing homework which was given in the last session. And then we will start the session by talking about a new skill, establishing a rationale for the skill, and we discuss the steps which is needed for this particular skill. And there will be, as I said, there will be at least 3 PGs involved, and the skill will be demonstrated in a role play, sometimes a bad role play, sometimes a good role play, and the clients are asked for what went right and what could be improved. And the therapist who acts as a facilitator takes pains to make sure that everybody in the group involves and gives some suggestions. Then we call out 2 other residents who are 2 rehab residents to participate in the same role play. And then we again take feedback from the group of our inpatients, our residents, and then the feedback, apart from the feedback that their fellow residents give, the therapists also give feedback to the people who are playing in the role play. And it changes. Who participates in the role play changes from day to day. Again, the role play is repeated by another 2 residents, and homeworks are assigned. So role play examples could be skills like requesting for TV remote. Because ours is in coastal Karnataka, we have people speaking multiple languages, and there is always a fight for TV remote. Somebody wants to watch, listen to music, somebody wants to watch Kannada serial, someone wants to listen to news and things like that. So requesting TV remote is an instrument, it's an important skill so that we prevent multiple fights from happening. How to report a problem they have with other staff in the rehab to consultants in rehab center. So these are some of the skills that we take apart from things like how would you greet another fellow resident and things like that. So our index patient had both individual sessions, initial 6 sessions, and then group sessions he was attending regularly along with OT sessions and other things. And after we reviewed the patient after 3 months, at this point of time, he had no positive symptoms. He was interacting well with with other residents and as well as staff in Hombelaku. However, his initiatives for social interaction remained low. If you remember, premorbidly also, he's an introverted person. So he would not go out and make conversations, but he was friendly with the people in his room and things like that. He was regularly participating in occupational therapy as well as our vocational training sessions. At this point, he also started expressing a desire to work, to find an employment and start his discharge process. At this juncture, we again discussed with him the occupational plan, which will be discussed with him. And as Bhandary sir earlier mentioned, the skills possessed by the patient, the family vocation plans also were considered while discussing occupational plan with the client. And we came up with these particular options. We looked at option as to work as an engineer in a construction company, to take up clerical work in a college or office, which was the family's idea. We also looked at him as a teacher in a polytechnic college, or tuitions for students who are doing engineering. So these were the options that we came up with. To be frank, what he really liked was to work as an engineer in construction company, but then certain other issues came in because the software that he was familiar with in Australia was different from what they were using in India here. And he also felt that going from a rehab center to work would actually prevent him getting further job later once he's discharged because of stigma associated. And he wanted to start off slightly less intense work and to focus on things like being regular to his workplace and being able to hold on a job and things like that. And we looked at as a teaching option in polytechnic as a possible option. So in light of this, we thought of making a new social skill training plan in the light of his vocational plan. So we started off with focusing on preparing for an interview, preparing for classes, preparing training for taking a class, and maintaining discipline in the class. So at this point, another therapist was involved in preparing for an interview. This was done about in 2 sessions. So the therapist helped him to make a CV. If you remember, at one point of time, he would refuse the CV to be uploaded, saying that people would steal it. But however, he himself came up with making a CV. But one of the interesting factors at this point was he himself came and told us that, look, I don't think I have adequate clothes for the interview and I should bring more better clothes from my house and things like that. The social skill training for interview focused on eye contact with all the interviewers, greeting the interviewers, answering questions. The therapist conducted mock interviews with the client and like role plays. So therapist will be the interviewer and resident will be the person who is coming for the interview. And after each role play, we would give feedback and further training was done. He actually went and attended interview. What we didn't anticipate happened, he had to take a mock class to the vice principal and 2 staff. We actually didn't anticipate this will happen at that time. The remarks we got from them was that his content, his knowledge, etc. are okay. But however, he looks anxious and his voice is not very loud. So on parataxical skills, they had problems, and they were also looking at, they were willing to try him on a trial basis. We again came back and discussed this suggestions from interview with the client. We discussed about his strength and weakness for the proposed job with him. And we also looked at, since he had never taken up a teacher's role, what are the possible problems that he can anticipate in this. At this time, what we sort of came up was that positives for taking up this job is he has good technical skill. He has worked as an engineer. He is someone with fairly good academic record. He's motivated for work. He has adequate self-care and grooming. And interestingly, he studied in the same college where we were planning to place him. So the staff and teachers were nicer to him. What the areas we found to be important was that change of career and place. He was unprepared for taking class. He had anxiety about having to face a large group. We also had concerns with paralinguistic skills, tone and volume of speech, things like that, etc. And how to interact in groups. This was something that we felt that would be the hindrances for taking up this job. So right now, our social skill training again became more individualized, and we looked at skills like eye contact with the audience, tone and pitch of the voice, organizing material for class presentations, facing large groups, and maintaining discipline in classroom. So to increase volume, tone of his speech, we actually, what we did was we looked at giving him an auditory feedback. So in a big hall, he had to speak, and the therapist would record his speech at 3 space points near to him, in the middle row and the last row. And then this feedback was played back to him and said that, see, this is why we think we have to focus on increasing your voice levels. But then he came up with saying that, I don't think I can speak any more than in a volume higher than this. So what we did was we asked him to wear an earphone with some music playing while he has to speak. Again, we recorded his speech at 3 space points, and we played it back to him. And this time his tone has actually increased, contrary to his expectation that he can speak only in low volume. And he decided to, let us tweak his volume level. Then we encouraged him to make 10 to 15 presentations and present to the social skill trainers. And the therapist one person would stand near him, middle, and the last row, and they would raise hands and give him visual feedback when they cannot hear him. And after each so when they raise their hands, he increases his voice like that. So we made sure that increased voice was maintained throughout the presentation. That was the goal. We also gave feedback regarding eye contact and other non-verbal aspects of presentations. He continued making similar slides, and then we again put it back into a group. So we were having other clients who were receiving similar training. So we put all of them into a small group, and each of them would present for 15 to 20 minutes, and they will get positive and corrective feedback after the presentation from both their own group as well as from the therapist present there. Once he was comfortable doing this, in our rehab center, we also have monthly once family meetings. So the family members of the residents come and join us for a session on post-lunch Saturdays. So we asked him to prepare and present a slide for them. And that was obviously taking it to the next step. And again, from there, he was given positive and corrective feedback. And we also looked at possibility of giving topics of increasing difficulty level, started from fairly fundamental general topics to slightly something more specific and in the context of his educational background. The feedback given was generally regarding pitch, tone, volume, content, and overall style of presentation. After receiving few sessions like this, he reported that he doesn't feel any anxiety, and he also felt that possibly he can manage a class. So he started going to work. It also took us time to send him to work because in between the college had exams, college had holidays, and so we had to wait a little before we could send him to work. So when we started work, we thought of grading the load of work. So initially he was taking only practical session. The psychiatric social worker consultant would make visits in the workplace, Mr. Praveen, and he would take feedback from principal and staff of the college. And this feedback would be used in subsequent sessions which we have having here. We also focused a little on maintaining discipline in the class because these are undergrad students and they're quite energetic. So some of the sessions were what happens if in this case, in this kind of situation, what will you do? That kind of thing was done. At this point of time, he also started shopping up for himself alone without supervision. So he could go and buy things for himself and come back. And after 1.5 months of working, we made a plan for discharge. So the discharge plan was that he would continue to work in the same college from his home. We were able to discharge him in August 2015. The last follow-up was this month, 2016. He still goes for work regularly. He has done invigilation duty this time. He does both practical as well as theory classes. He has good IP relations with colleagues, and he travels to and fro 15 kilometers to reach workplace alone. He manages his lunch and expenses on his own, and he currently, I'm sorry for the spelling mistake, he currently earns about 12,000 rupees per month. We're not very sure about future plans. We're not very sure about what to do with wife and the child, even though he wishes to meet them. He has not made any inquiries or called to check on them. His family of origin also feels that till he reaches that occupational functioning, which was his before, and he can earn slightly better and he can deal with the responsibility of family life, till then we will not initiate contact with the wife, is what primary family of origin feels. They also have a hope that he might be able to go abroad and join wife at some point of time in the future. When we put this case together into a presentation format, what we felt that it was very different working with this client. One thing was that we had good family support. He had more or less adequate cognitive skills, and we were able to utilize community resources to place him and to train him. We also had to deal a little bit with the issue of migration. He is separated from his wife, and there is, even though he is earning 12,000 per month, there is a huge disparity in the amount that he is earning. And one of the challenges that we felt was to design an intervention to suit his occupational need. And there were multiple therapists involved. Maybe that helped in better generalization of skills, I'm not very sure. And it was very important that all the therapists communicate between themselves. And it took us around 3 months to identify and get a job for him. And what we also found was that the moment he started going for work, and we started designing the social skill training in his workplace, he was more motivated for attending the sessions. I think I'll end my presentation here. I would like to, we both would like to thank Dr. PSVN Sharma and Ms. Shalini Kodros, Dr. Abarajida Vishateja, Arpita Suhavan and Shabdida from my department, Umesh and Prithviraj from PSW. And we would really like to thank that friend of Hombelaku, the college which provided him the employment opportunity. Thank you.
Yeah, that was a very interesting presentation from Manipal. Now, it's actually when I'm listening, when I listen to your whole presentation, it sounded a very, a situation which is like, it seems very favorable for this kind of interventions. So it would be, you did cover this, but it might be useful to all the listeners if you could just list the factors that helped you in this case, in, implementing the plan in this case, and as well as the challenges that you have faced.
Okay.
I think we did reflect on the plus points in this individual. One is a good family support, fairly good cognitive skills at the
Hello?
the time of the intervention also. The positive symptoms. Hello?
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 Yeah, just a minute.
Yeah, we can hear you.
I think the Manipal team is a little bit slow at times. So if you give them 2 minutes, they'll probably be able to. So,
Okay. Yeah, so as Sir was telling, he was mentioning we had pretty good family support, and he had fairly adequate cognitive skills. And one of the other advantage was that he didn't have any positive symptoms during the intervention time. And so there was no disruptions that we would otherwise generally see in our clients, and that was one great thing. The other thing was, I think we had a team of quite a lot of people who are interested and invested.
Yeah. And the other thing was also his ability to speak in English. I think that was a real positive thing, because we could
we all could speak.
Yeah, the possibly for the therapists also, as well as a certain of the high functioning clients, they could mix together with a common language, and that provided a forum for good social skills training in a group setting.
And I think at this point only we decided to divide people according to their functioning levels and do training accordingly. So we had people with primarily negative symptoms, people who were a little bit more better functioning, and people who almost had disorganized symptoms also in our rehab. So we divided them into 3 groups, and we focused our interventions in the group sessions accordingly. I think that also helped.
Actually, reflecting back, when we first saw him, it was we didn't really expect him to reach up to this level of functioning, because the level of deficits was, I don't know whether it was partly contributed by his personality of having some amount of anxiety. Even if another fellow resident had abused him or hit him, he didn't even report, and it was only coming out when we had got this information, and we just inquired, did this happen? And I said, yes, it did happen. So what do you want to do about it? So I don't know. For most of the things, he would give only a blank answer that I cannot make any decisions. I am not having any decisions. I really don't know how to go about it. And it's possibly when we reach the work aspect, he did have only one motivation. One thing that was motivating him was the discharge. When can I go back home? When can I be India? With my family. And when this need for getting into an occupation was emphasized, and then he starts working on it from his side, and the cooperation started improving. And because once the topic of getting an employment came in, his participation really changed quite a bit.
Thank you. I think you've answered the next question as well, which was about his level of motivation. I think we have a question from Dr. Pawan. Dr. Pawan, yeah, you could please ask your question and unmute yourself. And to the Manipal team, you could, the slide share, you can perhaps stop that for now, ma'am. Thank you.
Slide share, stop share.
Stop share, okay.
Yeah.
Dr. Pawan, you can go ahead and ask your question. Okay, I think Dr. Pawan's having an issue with the sound, but basically he wants to know what Malik's manual is. So if the team could enlighten them about that.
Okay. I think people from Nimhans will be better suited to answer this. It's the BELAX manual is that social skill training manual, which is for schizophrenia, which gives you a fairly initial introduction about what are the skills that are involved, why social skills are important. And if my memory is right, it also has a chapter on assessment where they talk about Maryland assessment of social skill. That part is quite well elaborated. It divides social skills into different components, as Vidhi was talking in the initial part, and it actually gives you blueprints for conducting each session. So it says, okay, fine, greeting. So how will you do greeting? How will you divide it into steps? And how will you give the rationale? And how will you troubleshoot? And you can actually get the manual, I suppose.
So
I think Poornima ma'am would be able to answer that.
BELAX manual, I definitely found one copy online, so I'm assuming that it will be available to everybody. It's a very structured manual. It's one of the older manuals, but it tends to focus on social skills deficits primarily seen in schizophrenia. So I think it takes a little bit of tweaking on a therapist's part to see how to use it with different kind of deficits. It's quite useful because it's quite structured, but that in itself also becomes a challenge because most of the work is done in group settings. It's not always possible because of practical considerations, language, and other considerations to have groups. Some clients benefit more from individual work, and BELAX manual doesn't give a lot of direction on how to tailor make things. The other issue is also the cultural context. Some of the manner in which someone is meant to be assertive or ask questions may not always fit into our cultural context. So I think if you keep the basic behavioral principles of BELAX manual, but adapt it to our setting and the individualized needs of clients, it can be quite a useful tool for people to use. I do think though that with so many centers doing social skills training, it's important for us to perhaps bring out some of our own material, which is reflecting cases like that you have presented or other cases that we have worked with, so that we can look at how it's adapted to our context. So I do hope that maybe today becomes a catalyst for us to move forward in that direction, and I'll definitely be contacting your team later for that.
I think that's wonderful, ma'am, because that's one of the problems we have with the BELAX manual. It actually helps residents in their first year to get an idea how to conduct a group and things like that. But as you rightly said, it does offer some cultural problems, especially there are dating skills and other things also involved in it. So we have to modify it quite a bit to bring it to our kind of context.
To add to it, I think we'll have to add one more acknowledgement. That's how to increase a person's volume, and they had suggested these methods, and we could incorporate in this individual and give him that benefit.
Thank you, sir. Dr. Padmavi has another question, I think, as well. Madam? I think Dr. Padmavati has a question about the rigorous documentation that Manipal is known for, and she wants to know how we document the interventions that go on so that the rest of us can perhaps take some lessons from that.
Documentation. I think that is our weak. We actually think it's our weak area.
Frankly speaking, with regard to interventions, or at least in our rehab setting, we have having this one difficulty because it involves multiple people. It often doesn't get recorded in a structured way. One possibly puts a subjective note that this was the change that was seen, or possibly gives some example about where the person showed a positive change, or where that requires an improvement. What we do have structured documentation is that at the time of intake, and recently we have started off with a telephonic follow-up. So we have made one structure for following up over the telephone about the progress, and trying to keep it simple, we usually give it in a Likert scale, asking the family members and the patient to rate, say how best is their communication, or how well are they able to get along with people. So right from very well, not so well, etc. So if you go by the scale, so possibly we are not yet maintaining that amount of recording, but we do hope to. In fact, when you were presenting about the social skills, the SASS scale, we thought we can incorporate this rather than the old checklist, which was a little on the vaguer side. So we are in the constant process of improvising, and
I think one of the things we have is because we have residents, psychology, social work, and psychiatry residents posted with us. One task they have is to summarize 1 week's interventions and put that as a note. And each month, when they shift out of the rehab, they're supposed to put a summary note. So that sort of helps us to keep track of our patients, especially those who are in long term. And I think every week they're expected to do a mental status examination and record that as well. So that sort of helps us to keep a track.
That's good.
Any more questions? Okay. I just wanted to come in with a couple of observations. One is to thank the 3-member team at Manipal and the many members behind that who have really worked so intensively on this case. It was really a very interesting case. What struck me is the 3 I's in this case. You know, it was intensive, it was individualized, and it was quite innovative. So I think these characteristics of the case really stood out. I would also tend to agree that in our experience also with clients, when we have anchored the social skills training along with a workplace, a return to workplace or return to vocational functioning, then the motivation of the clients really seems to go up. And we are also, I think, able to tailor it in a way that is much more meaningful. So more and more, I think that with select clients, we should transition fairly quickly from the initial social skills intervention to one that is focused on a more tangible kind of context for them. I think that we have also, I agree, found quite useful. Another observation that I have from the point of view of social skills training, that many of us who work in this area tend to focus much on the behavioral skills. So we follow Belak's manual, or we follow other literature that we've gone through, but we focus much less on social perception, social cognition, or social problem solving. And for that, I think it becomes even more culturally contextualized. And I think that these are areas perhaps we need to move forward, have quicker assessment methodologies, and have more structured interventions that we can do in terms of social perception and social problem solving. Those are some of my observations. I'd be interested to know what you feel and the other participants as well.
I think, ma'am, that's a very valid point. And one of the co-therapist, Umesh Kanse, his PhD is on these lines, on social cognition, being guided by Dr. Rishikesh Vidhi. I think he's known in the field of social cognition, and he has been doing interventions. I think he missed out on this individual at that particular time, but otherwise he has been using that as an additional method of intervening.
He has a social cognition group that he runs as a part of his PhD work, and he meets these. He comes to our center and he runs this group, which is weekly once, I believe. So we do have that, but that is still somebody's research.
I think that I met him when he was in the more initial stages of his work. So it's good to know that things have progressed like this, and maybe it can translate into things that we can use more. So thank you for sharing that information. Can we close? So we'll close today's session unless there are any last minute.
I just want to make one comment. I think a lot of talk was on Belak's manual, but I could see that you have innovated a lot also. So Poornima was hinting at having our own manual. So I'm just cannot resist the temptation to say that what was followed was Nitha Thomas model. So it has borrowed from Belak's, but I think I mean, this is what we need. I think we need to individualize and innovate. And one more I would be Indianizing. So this case example shows that if we work intensely and work with the intention to help the patient, ultimately not really not trying to stick to some manual. You need to innovate and ultimately to help the patient. It seems to bear fruits. Thanks very much for giving us this wonderful presentation.
We thank all the participants for coming into the session. For those people who have participated through classrooms, we would request you to individually register on the link, because those people who have registered and who have attended this session, we will be sending you a link for feedback, and those who fill it, we will be getting a participation certificate. So we'd request you to do that. And second, people who are interested in the social skills scale, which was discussed by Ms. Vidhi and Dr. Poornima, please send us an email at nimhansrehab@gmail.com. We would be happy to send you a copy. The next session is on 26th of February. The theme which we have taken up is rehabilitation in adults with intellectual disability. So here we will be having a case presentation by Seva in Action, which is an NGO based out of Bangalore, which works with individuals with intellectual disability. And we will be having a didactic session by Professor B.S. Chavan, who incidentally also happens to be a Padma awardee for his work on placement of individuals with intellectual disability. They will be sharing their experience of how to use the National Trust Act in the rehabilitation process. I'm sure that it's going to be an interesting presentation which all of us can use in our routine clinical practice. We thank you all for the active participation, and we hope to see you again on 26th of February. Thank you very much.